Hello, everybody. Welcome to another webinar from the LCH Steering Committee. For this time, we have thought it would be good to talk about sclerosing cholangitis in LCH. So before I start, there are some housekeeping issues. First of all, a little bit about Histopathology Society. A majority of you know that this is an excellent not-profit group, which at the moment encompasses over 250 physicians and scientists from all around the globe. The society is entirely committed to advancing knowledge and improvement of outcomes for patients with histiocytic disorders. The society has a focus on clinical and basic research and education. And as I said, this session is hosted by the LCH Steering Committee. Just a few important things. All the participants are muted at the moment. And please submit your comments via chat feature in your panel. And then your chat will be seen by the staff and the panelists, and the chat will be in control at the bottom of your screen, as you can see on the right. And after clicking, the chat window will appear on the right, and then you can type your message, and we will press enter to send it, and we will do our best to answer it. Please put the question for the speakers in the Q&A box. This will be addressed at the end of the talk, so please indicate who the question is for. Put the question for the staff in the chat box, and like a question in the Q&A box if your question has already been asked by someone else. And we might not be able to answer all of the questions, but we will try our best to do so. So this is a way to become a member of Histopathology Society. Please email, and we will try to do our best to encourage you to be a member and include you. It's a very, very inclusive society. I've been a member only for a few years and felt incredibly welcome and supported in the work of the society. So these are our speakers and the themes that we are going to discuss today. I will first deliver some basic information about sclerosing cholangitis in LCH. After that, Dr. Jean Donadieu from Hospital Trousseau in Paris will talk about sclerosing cholangitis in LCH, treated with MAPK pathway inhibitors. Following that, Jen Picarsic from Children's Hospital in Pittsburgh will talk to us about novel insight into histopathology of sclerosing cholangitis. And following that, Dr. Julia Minetto from the Pediatric Hospital in Buenos Aires will talk to us about the role of surgery and liver transplant in sclerosing cholangitis. We have also a number of panelists. We've got Dr. Guido Felicia from Argentina. We've got Dr. Jean-François Amil, the eminent pathologist from Paris. And we've got Matt Collin from Newcastle. Unfortunately, we don't have Dimitri. He's on holidays. So a definition of sclerosing cholangitis. This is a chronic, progressive fibroinflammatory condition of the intrahepatic and extrahepatic biliary tract that eventually and unfortunately leads to hepatic cirrhosis. So a little bit about LCH in liver and sclerosing cholangitis. So liver involvement altogether is present in approximately about 20% of all patients with LCH. so including all comers, single site and multi-system disease and so on. Liver involvement presents as either liver enlargement or liver dysfunction with hyperbilirubinemia, hypoalbuminemia, transaminitis, and so on, or histopathological findings that indicate a liver disease. The liver involvement in LCH is more common in multi-system disease, which is not surprising. So about 50 to 60% of patients with multi-system LCH have liver involvement. Subset of these patients who have signs of cholestasis progress to sclerosing cholangitis, and that is about a third of all the patients with liver involvement. Sclerosing cholangitis in LCH represent approximately about a third of overall cases of sclerosing cholangitis in children, because sclerosing cholangitis in children could be due to immunosuppression, due to inflammatory bowel disease, cystic fibrosis, and so on. Unfortunately, in LCH, progression to the end-stage liver disease is more rapid than in these other conditions. So how do we diagnose cholangitis? We have imaging, ultrasound and MRI might help us. Cholangiography, especially magnetic resonance cholangiopancreatography, is very helpful. Transcutaneous liver biopsy is very often non-diagnostic because we don't have CD1 positivity or Langerhans positive cells, but we have the reports of biliary obstruction and ductal sclerosis. I'm sure Jennifer will give us some more insight on histopathology. Histopathology and imaging are also important for assessment of disease progression and in order to plan further treatment, especially liver transplant. So what do we do to treat these children? First of all, we treat multi-system LCH. We use chemotherapy or we use MAP kinase inhibitors. And while this helps with the treatment of the liver disease, it doesn't help with sclerosing cholangitis. However, both of these treatments might improve patients' overall condition, so they can go relatively well into a transplant. There is a caution with hepatotoxic chemotherapy drugs, especially vinblastine, and therefore quite a few people advocate modified chemotherapy, especially to use cytarabine instead of vinblastine. The only definitive treatment for sclerosing cholangitis is unfortunately liver transplant. We currently don't have anything better. Just a couple of details about liver transplant. There are a couple of papers that report on this, and one comes from US population analysis using a scientific registration of transplant recipients in the US from quite a long period of time, which reports on only 60 patients, 55 of whom are children. 49 of them received deceased donor, or as we say in the UK, cadaveric liver transplant, and 11 received live donor liver transplant. Overall survival for this population was excellent and varies from 86% at 1 year to 82% at 5 years. The same authors have done a systematic literature review, and they identified another 50 patients, 41 of whom are children, and 34 of these children underwent transplant with deceased donor liver transplant. It's interesting that they found that the recurrence of LCH in the liver only in 8% of people, of transplant recipients, and only 11 of 50 patients died, but none of them due to LCH. There was no information about the timing of transplant and disease status prior to transplant in this paper. The group of clinicians and surgeons from India, from Chennai Hospital, report in their paper an algorithm of how they manage patients with sclerosing cholangitis. They put patients into two categories. In category one are patients with what they call compensated liver disease, which they treat with standard chemotherapy. And then they do liver transplant once the chemotherapy is completed. In category three is two is a little bit different category, where they have patients who have decompensated liver disease, really acute on chronic liver failure. First of all, they treat these patients with modified chemotherapy using cyclophosphamide and steroids. And then they undertake liver transplant immediately after induction chemotherapy, and then complete maintenance chemotherapy post-transplant. They do this provided the patients are in remission. They've used this approach for 6 patients, and 30 months post-liver transplant, all of them were well and alive without disease. So these are questions for today's webinar. Does MAP kinase inhibitor therapy help with sclerosing cholangitis in terms of treatment or preparation for liver transplant? And I'm sure Jean will tell us about this. What are the criteria for liver transplant in children with sclerosing cholangitis? When is the best time to transplant? Should patients be transplanted early, as soon as they achieve remission of LCH, if there is a progressive sclerosing cholangitis? And our pathology is better in diagnosis of biliary fibrosis despite the lack of the usual LCH markers. So that is my introduction, and I think it would be good if we could start with Dr. Jean Donadieu with his presentation of MAP kinase inhibitors in sclerosing cholangitis. I don't think I need to introduce Jean any more in detail. So please take it away, Jean.
So thank you, Olga, and thank you to the Society and Cathy to organize this webinar. I will present an experience. Do you hear me? There is no, everybody is fine. And can you see my screen also?
Yes, okay. We can.
So I will provide a short summary of our experience collected in the what we call the ECHO group, European Consortium for Histiocytosis, which is a little larger than European country. Like we have also colleagues from Argentina and some colleagues from North Africa. And so we have gathered some experience, and I will start with this experience. And I will, our approach was to provide a off-label MAP kinase inhibitor. And we just want to share this experience here. We have provided an abstract at the last Histiocyte Society Congress, and I have a little expanded this, and we have a manuscript in preparation, which allow us to go in more comprehensive way of all the data presented here. So sclerosing cholangitis in LCH was known in the 80s. I have found this paper from a French team, but I think there is also other report. So in 1991, 81, and typically the lesion is in the liver is like a onion bulb on the duct, on the biliary duct, and you may imagine that with this kind of fibrosis around the duct, it's the biliary is not normal fluid, and there is accumulation of biliary in the liver, which result in a secondary cirrhosis, like this picture of explanted liver. And of course, we have faced to children with such a massive liver failure with a cirrhosis, ascites, and denutrition also, which is a part of the problem. And this subject was supported or bearing by the Argentinian group and Jorge Breyer, who reported about 20 years ago about 12 patients. And also, as you mentioned, Olga, we have the report of the US group of liver transplantation with 60 patients, and the survival with reported both adult and children is about 80% after liver transplant. Liver transplant being the main therapeutic option in this disease. But there is plenty of question about when to transplant, what chemo before, and what chemo after. And so we have not all the solution here. We just we will just report what we have done. And so it's a partial approach. It's observational because the number and the scattering of the disease is so high, the number is so low, and the scattering is so high that we cannot organize a real prospective study. And most of the cases reported are in a short series, and so we try to gather our experience. And we gather this experience with a MAP kinase inhibitor because MAP kinase inhibitor in LCH offer a possibility of treatment for refractory disease with active refractory disease. We have published this, and it is in the therapy of LCH since now 10 years ago. But we have limited information about the situation of sclerosing cholangitis. And so at the occasion of a larger study, we have about 277 patients included, we focus on the patient for which sclerosing cholangitis was found by different methods, by MRI, by ultrasound, and so we focus on the patients who have received MAP kinase inhibitor. We evaluate the response on a liver MRI, if possible, but also on the biological test and functional test. And of course, we have a big interest on the liver transplant. So for this, we have finally identified now at the last update 23 patients with sclerosing cholangitis. We have information about the molecular background in 20. In 3 patients, the molecular test cannot be available, probably because of quality of the DNA, and or maybe because there is no mutation. We are not sure. And but we have so the information for 20 patients, and most of the patients have a BRAF V600E mutation, and 2 others have one MAPK1 and other BRAF deletion. The indication, and so it is always complex situation, but the main indication of the MAP kinase inhibitor was sclerosing cholangitis purely primitively in 10 patients, and in 13 patients, sclerosing cholangitis was associated with refractory disease, and so there is several clinical targets for MAP kinase inhibitor. One is sclerosing cholangitis, but also the systemic disease. The median age of this series is 1.5 years about, and we have babies about 3 months, but we have also till age of 7 years, and the older one was I think was a teenager, but so it was not it was an outlier. The follow-up of this series is 3.2 years, and so it begins to be informative. MAP kinase inhibitor therapy was vemurafenib in 15 cases, Dabra in 5, Cobi in 3, Tramatemib in 5, and some patients have received two MAP kinase inhibitor. The median duration of the therapy by MAP kinase inhibitor was 2.2 years. What is important in terms of adverse, it was the adverse event. And what we have observed in terms of adverse event was quite limited. The big surprise or somewhere was to have not seen any liver side effect. Some patients have a progression of the liver failure, but it's hard to consider this as a side effect. It's more a progression of the disease despite the treatment. But clearly, we have not liver failure related to this therapy. We have observed mainly skin rash, and we have periannexis with MEK inhibitor. One case have a lymphoma, but it was a post-transplant lymphoma. So if we look to the response, and it's more comprehensive than in Goa, and we have more detail now. Well, if we look to the patient who have a primary indication for sclerosing cholangitis, so we have almost no response. All the patients have a progression of the liver failure, and all 8 was transplanted, and 2 are waiting a transplant. So in this group, for which probably the sclerosing cholangitis was a fix, was not at the beginning, there is no effect. In 13 patients, we have both refractory disease and sclerosing cholangitis. And in this group, we have no response in 5. And so for this group of patients, there is either a liver transplant or indication of the liver transplant. We have 5 patients still without liver failure, and we don't know if there is a good response or it is just a stabilization. And in 3 patients, and we are very cautious, we fail to see the sign on the of sclerosing cholangitis on the various tests, and including the MRI. And so maybe it's too early to say that we are winning the aim to control the sclerosing cholangitis, but clearly I think that this group is patient with limited symptoms or limited sclerosing cholangitis at onset, but maybe we have provided a good response for a few group of patients. If we go to the patients who have been transplanted, so 10 patients have received a liver transplant. The median time from diagnosis to liver transplant was about 1.5 years. The median time of MAP kinase inhibitor before a liver transplant also 1.5 years. So they have been treated seriously by MAP kinase inhibitor, and the median time after the transplant was about 2 years. The single and major complication observed was a secondary lymphoma, secondary to EBV lymphoproliferation. Among this group of patients, two patients have withdrawn MAP kinase inhibitor because of lack of efficacy before liver transplant. And so 8 patients received MAP kinase inhibitor during the transplantation period. We observe 1 relapse in a patient who have not receiving MAP kinase inhibitor during the transplantation period. It was a patient who have inactivation of the MAP kinase treatment by rifampicin, who was prescribed because of the scratch. I think it's a drug for that. And this liver nodule related to LCH was easily controlled by resuming the vemurafenib. And lastly, after the transplant, 4 patients withdrawn MAP kinase inhibitor without reactivation. So they look like cured because they have transplantation working normally, and they just have immunosuppression. No patient has been retransplanted, and no patient died from this procedure. And no patient died at all in the group of 23 patients. So in conclusion, we are still cautious because of the number, but we have the feeling that MAP kinase inhibitor probably is not the good app. There is no effect on the sclerosing cholangitis once this is fixed. But the interest of MAP kinase inhibitor was to prepare to the transplant, meaning that it's not an immunosuppressive drug. And it helps to control the LCH without immunosuppression. So that's a very preliminary results, and we have this work ongoing. I just want to finish by saying a big thanks to all the network. We have more than 200 colleagues who have participated to this work to provide information, and so it's a significant effort, and we hope to publish this soon. And so thank you for your attention.
Thank you very much, Jean. It's an excellent, crisp presentation. I thought for the sake of speed, it might be good to go to the second presentation and then do all the questions at the end. Please keep your questions, and we will try to answer them afterwards. So our second speaker is well known to our team, is Dr. Jen Picarsic, who is going to talk to us about novel insight in pathology of sclerosing cholangitis. So thank you, Jen, and thank you for making it.
Can you hear me okay?
We can.
Okay. I'm in the airport, so I apologize if there's noise behind me. Just let me know. All right. Well, thank you to the presenters and Olga and Kathy for inviting me today. This work was also previously presented at GOA. So as we have learned and heard, liver involvement in long-arm cell histiocytosis has about 2 different forms. We don't really know what the pathology in cases with just hepatomegaly look like, but in those cases with what we know is the sclerosing cholangitis, we do know that under the microscope early on, there is more of a chronic inflammatory and early portal edema, not as much fibrosis at the very earlier onset, but does have a cholangiopathy appearance. And as we said, the longer N and CD1A at this stage can be variable, demonstrated in some cases, but not all. And in that late phase that John showed, there's a lot more fibrosis. That's where you get that onion skinning fibrosis around those ducts. And with that ongoing injury, actually then leads to this end-stage liver disease, which we call a biliary cirrhosis pattern. And then often with liver transplantation needed. Slide. Okay. Oops. Sorry. There we go. Okay. So this is a very rare example of a liver biopsy that actually does show CD1A and logrin actually going up into those distal bile ducts. This is a very rare case, and it's an active one in which, as you can see in the lower panel with the green circles, these are very destroyed bile ducts with inflammation in a really active phase. And the reason that we often don't see the CD1A and Longren in those distal bile ducts is that it is much more centric on the larger bile ducts in the hilum, so extrahepatic in the larger intrahepatic bile ducts. And what happens is there is inflammation, and the LCH involves those larger ducts, with over time having a more injury to those. So the end stage fibrosis is more of a cholestatic injury pattern. You can see there's bile plugs within those larger ducts, leading to this irregular cirrhosis pattern with a lot of ductular proliferation. So my keypad is a little sensitive today. So sometimes at liver explant, when you really block out that hilum area, you can see areas where there are just remnants of ducts, and you don't see that biliary epithelium anymore. And what results is this sort of obstructive pattern. There can be a variable amount of cholestasis, foamy macrophages filling those remnant ducts, no or very little CD1 or A or Longren. And in such cases, previous to our BRAF known era, these were just considered burnout LCH cases. But as we've learned from other examples in diseases, we know that at one point CNS LCH was thought to be a paraneoplastic process, not an LCH driven, because we didn't see the CD1A and Longren cells. But now we know that there are these forms with a macrophage predominant CD163 and BRAF mutant population in those neural inflammatory regions of the brain with the gliosis or neurodegenerative changes. So the question is, could a similar process be happening in LCH? And so, we think we know, but we don't really fully understand the pathobiology of hepatic LCH. There is an inflammatory component. Is there any stage in which this is reversible? Can it be prevented? Why the bile ducts in particular? And then, as I alluded to before, what happens when we have this sort of lineage switch and have more macrophage predominant? Is this burnout or is this a different form of active smoldering disease? So we had looked at our cases and trying to understand this in more detail. And sort of the question was, is there a mutated histiocytic population that's contributing to this active smoldering disease process despite the lack of the CD1A and Longren? So in our files, we found, looked for cases with both pre-transplant biopsies paired with the liver explants from LCH patients, particularly looking at the BRAF V600E mutant patients. And we have always sort of done a serial block sectioning of the hilum and then paired that with immunohistochemistry and molecular testing in those cases with the BRAF VE1 positivity. And in our cohort at Cincinnati Children's, we did find 4 cases. They were all white males with a median age of about 4 years. And of course, all with the BRAF V600E and thus, by definition, a high-risk LCH. And similarly, all 4 of the cases had this ductular proliferation in the early stages of biopsy. So as sort of outlined, the portal areas are expanded by this loose, more fibroedematous expansion with a lot of ductular proliferation. And when you look on trichrome, this is not yet a cirrhotic stage. This is more of what we call fibroedematous changes. It's a lighter blue pattern, sort of expanding at that limiting plate. And when you do a stain, a dye to look at those ductular profiles, normally in the portal area, you should only see one bile duct. You shouldn't see this proliferation. So this is indicating that there's a proximal obstructive process happening, and now you have all these proliferating ductules starting to be evident at the limiting plate. So this can be seen in any type of biliary obstructive disease, not just LCH in particular, but in cases it becomes very challenging in which there's often, as Olga said, there's often not that CD1A logrin if the disease cells haven't increased all the way up to those distal ducts. So it can be very challenging. Now, I will say that in a known LCH patient with this pattern, it is diagnostic of disease. In rare cases, we can see that BRAF VE1 in the bile ducts, and in our cases, we did demonstrate that. If you can see in that counter blue stain, this is a bile duct profile with a mutant cell infiltrating it. And in some of these cases were confirmed with the ddPCR. So when we look in more detail at the actual 4 cases at their explants, they had very interesting pathology. So the first case was transplanted at about 2 years old. He had a liver biopsy about a year before that. He was on standard therapy, but failed and switched over to inhibitor therapy prior to transplant. His blood was positive both before and after transplant by our ddPCR testing. And it was interesting, and as I had alluded to, in the large bile ducts, they were obstructed by this macrophage-rich population, and we carefully microdissected out this area, which was also positive for BRAF V600E. 6 years post-transplant, the child is doing well and thriving, but does remain on both the BRAF inhibitor and his immunosuppression for the liver transplant. Case 2 was similar, transplanted about 3 years old with a liver biopsy about a year before. Again, failed standard therapy, but was started on inhibitor therapy prior to transplant. Similar story with positive blood testing both before and after transplant. This case had a more bile stasis, a bile lake, but with surrounding macrophage predominant infiltrate around that cholestasis, and a subset of those CD163 positive cells did demonstrate the mutant specific staining for BRAF. This child is also doing well after transplant, a year after. Case 3 was different in that this was an older child and actually thought to be cured by standard therapy, but did have a known sort of persistent PET positivity in the liver and was known to have chronic liver disease, but was sort of being followed. He did not have testing of his blood prior to transplant. We didn't really know about this patient until they showed up for transplant. But in the hilum, there were similar areas with this fibroinflammatory admixture with a lot of CD163 macrophages in the large hilar areas. There were a few areas that were positive for the BRAF VE1 very focally, and they were also microdissected out and shown to be positive for the BRAF V600E. The patient is still doing well post-transplant and was on MEK inhibitor for 2 years, but then was able to be taken off and is only on the immunosuppression for liver transplant. And this is was just to show you in some of those BRAF V600E areas, a similar population was staining with P16, which is our senescent marker. The last case was more similar to case 1 and 2 with progressive liver disease, and then was switched to inhibitor therapy with having positive blood before and after transplant. The difference, though, in this case was that there was a lot more fibrotic changes as highlighted in that middle panel. You can't even see the bile ducts, even intermediate sized ones, because they're totally scarred down with fibrosis. Other areas that did have the cholestasis, there was some remnant CD163 positive cells. Now, I will say on this one, there was a rather long fixation, and we tried microdissecting out this area, but the DNA just was not able to show any amplification at all. So it was just too long of fixation, unfortunately. There was a little bit of staining, but unless I have it confirmed with the ddPCR, we're not able to say too much about that one. So it's just to show that, in all of these cases, this is this biliary cirrhosis pattern that we saw. And, looking at some of these ducts, both in ones that were not obstructed, you can see some BRAF VE1, both in that epithelium, as well as in those larger obstructed areas with the macrophage predominant. So, these are very preliminary findings. It would be nice to compare with the echo group at their explants also. But, it really seems that it is the subpopulation of CD163 and BRAF mutant cells that could still be contributing to maybe this low grade but persistent fibroinflammatory disease, this chronic biliary disease in these high risk LCH patients. It's a small cohort, and there was P16 staining in some of them that could correlate to this sort of similar pattern as we've seen in the CNS neurodegeneration of a possible sort of senescent population. But of course, further investigation is needed. So thank you.
Thank you very much, Jennifer. Excellent talk. I suggest we move on and hear our last talk, and then do all the questions at the end. So our last speaker is Dr. Giulia Minetto from the pediatric hospital in Argentina, the country that probably has probably the largest experience in treatment of sclerosing cholangitis. So, Giulia, please tell us your experience. Thank you.
Hello, everyone. Thank you for the invitation. So let's see if I can go. So liver involvement in LCH has been mentioned and talked about deeply. So I'm going to go fast. It includes liver enlargement, liver dysfunction, and even histopathological findings. And the problem with this has also been mentioned before. It occurs in 20% of the patients, and even if the disease is in remission, this could actually progress to sclerosing cholangitis, even liver failure and end-stage liver disease. So we reach the question of when do we indicate a transplant? In our series and in most of the published ones, the percentage of patients that actually need a liver transplant is close to 25 or 30%. This also has been mentioned before. So the clear definition of sclerosing cholangitis also has been mentioned before. And the thing that in this time, the progression is even faster than in primary sclerosing cholangitis, and it has less response to chemotherapy. So liver involvement together with spleen involvement and bone marrow is associated with high risk. And this is because the survival actually drops Without the involvement of these organs, survival in 5 years could go to 100, but if we include these organs, the survival can drop actually to 70%. And this revision was made like 20, more or less 20 years ago. So nowadays, the survival percentage could be a little different. The 70% could actually be a little higher. So this is our topic today. So what are the treatment options? First of all, the early start of chemotherapy, because early activity could be reversible with chemotherapy. This has been talked before. And my topic is the timing of liver transplantation. And this is a rather difficult question because we do have pros and cons according to the time of the transplant. If we do it too early, then we might do the transplant when there still is an active malignancy, and it's not recommended due to the risk of recurrent LCH. This, even though the percentage of recurrence is very low, the evidence is not that strong. But what it is clear that if the transplant is too delayed, is late, then the mortality and morbidity is going to be increased by liver cirrhosis and even episodes of decompensations. So we have 4 possible scenarios. The first one is when we have compensated liver disease and the LCH in remission. This is the ideal condition to perform the liver transplant. We do need to consider the complications that might have due to portal hypertension or even the pruritus and growth retardation. It is important to know that the timing of the transplant also is depends on whether the donor is liver donor or we need a deceased donor, because this might change according to one country or the other. This has to do whether we have the available graft to do the transplant, or we have to wait in the waiting list for a while. The second scenario is when we have the liver involvement decompensated, but the disease is in remission. Liver transplant could also be offered in these patients. In this case, we have to be careful because we consider this type of cases as acute and chronic liver failure. So we need to check for how many organs are in failure. We have the risk of doing a transplant when the patient is too sick to get the transplant. So it is the same that we do with other etiologies, with other chronic conditions, but it needs to be considered because transplant could be futile in those conditions. The third scenario is when we have, in this case, compensated liver disease, but active LCH. Now, what we try is to complete treatment with chemotherapy. The suggested time is 12 months, and then to have a negative PET scan. So if we accomplish the remission of the disease, then we go back to scenario number 1 and we can perform the liver transplant. As the condition in the liver is compensated, we assume that we have time to do the treatment in a complete way. The last scenario is when we have decompensated liver disease and active LCH. This is the most challenging scenario. And I have to say that we have to treat in a case-by-case analysis. We might have to change the chemotherapy agents, and even we might have to delay or do the transplant before, according to the patient's condition. The worldwide series, the Americans had been mentioned before. They had 60 transplants performed for LCH, but it's a long series. It was performed from 1987 to 2018. but we have to consider that this is an analysis from a secondary data set. The data was not especially created for histiocytosis. So know all the variables that we might be interested in are analyzed correctly. 82% of those transplants were done with a deceased donor, and 18% of those were done with liver donors. With regard to post-transplant complication, 55 had acute rejection. 13 of those require retransplantation, but it was not mentioned the cause of those retransplantations, but it was not mentioned that might be because of recurrence of the disease. 50% died due to diverse causes, and patient survival was close to 87% at 1 year, and then it dropped to 82 and 82 at 3 and 5 years. No difference were found between deceased donors and liver donors. Sorry, going back. Other series include the series from India, Dr. Rela. He has a transplant center, and he received 8 patients with hepatic involvement, and only 6 require liver transplantation. 4 had compensated cirrhosis and 2 decompensated cirrhosis, and all were alive and no recurrence. The conclusion he drew, and is close to what we all think, is that larger studies are needed because this is a very rare disease, and it's very hard to draw conclusions with the data we have so far. Other series, or actually are mostly published case reports and very, very small series. Turkey has 1 patient, Japan 1 patient, and so on, but all of them are very, very small. So let's go back to our experience. We have in our center 8 patients transplanted due to LCH. The thing that we need to consider when we talk on a transplantologic point of view is that in our country in 2005, the Pell-Mell score was included into the way we prioritize patients in the national list. This is important because this talks about how we get livers in order to transplant the ones that need the transplant. Other changes were also done during that time that include a change in the immunosuppressive therapy that we use and all the post-transplant care that we do in the follow-up. So even though we have a liver transplant done in our centers, we believe that it's not correct to analyze them all together. When we analyze all our cohort, we saw that the era of when the transplant was performed was a clear indicator that impact on survival. So I decided to actually separate those series. And after the change of era, after 2005, we had no mortality in the waiting list of this kind of patients, and we transplanted 3 patients. Those patients were transplanted in 2007, 2020, and 2024. All of them had multiple organs involvement, and 2 of those had signs of sclerosing cholangitis and complications of portal hypertension that allow us to prioritize them on the waiting list. 2 of those patients were transplanted with living donors, and the complications are all of them had something, but it's not easy to draw a conclusion from this limited data. So all of them are alive. The median follow-up is 4.5 years. No recurrence was seen in our series, and the results are comparable to other conditions. We have in our series survival close to between 85 and 90% at 1 year. So the conclusions or the take-home messages is that we need to start early the chemotherapy. and do not delay the diagnostic studies like the MRI or the liver biopsy, actually to see where we're standing, to evaluate the extent of the damage and the fibrosis. The structural changes like fibrosis have less response to chemotherapy and more progressive disease. And what we have clear is that the early consultation to either a pathologist or transplant surgeons is essential to proper plan the liver transplant in terms of waitlist prioritization, living donor evaluation, the type of graft, and the surgical planning. And nowadays, living donor due to LCH has similar results and survival than liver transplant performed from other conditions. Thank you.
Thank you very much, Julia. Thank you very much. Excellent talk. So we've got just a few minutes for some burning questions. One of the questions I think went to Jeanne, who Ashish is asking, Jeanne, did your patients have the circulating BRAF V600E measured?
Well, I have not analyzed all the information, but I can say that at least on 10, something like that, most of the, maybe only one of the BRAF V600E circulating DNA identified. Most of the patients have no circulating DNA. I don't know why, but it seems that the disease seems not so circulating to be short. You have no hypothesis on this, but it seems a little different than other risk organ patients.
Yeah, it's interesting because it looks like Jennifer can find them in the liver explants. The other question to you is also, how long was BRAF inhibition stopped in the 4 patients where you stopped them and where there is no recurrence?
Well, most of them after 2 years after transplant. So it's a very cautious stop, not very early after the transplant.
Okay, thank you. And there is a question that goes to Jenny from Osama. The question is, Jenny, do you think that anti-senescence drugs like mTOR inhibitors or venetoclax might help with patients with sclerosing cholangitis on account of what you've seen?
I'm a pathologist. I'm not going to comment about drugs, but possible. It is possible.
Okay, thank you. And then there is a question to, I think, to all of us. How frequent do we see only liver and gastrointestinal involvement in LCH without involvement of other systems? So, Jeanne, in your series, did you have, how many patients you had who had no involvement of other systems?
We have no patient like this in the series of MAPK inhibitor treatment, and in our registry, I remember 1 or 2 patients. So it's very exceptional, I think.
Yeah, I absolutely agree. I haven't seen any patients. And yes, Core agrees with us. He hasn't seen any patients. I think it's another comment from our adult colleagues. It's Dr. Goyal, who says that sometimes in adults we see liver dysfunction with tumorous lesions without obvious sclerosing cholangitis. And in these patients, the mortality is high. And he wonders if the mechanism for this is actually different in adults. The question also that comes from one of our adult colleagues, I don't think we should neglect them, is do we have any experience and do we have any experience with adult patients and the sclerosing cholangitis? I think probably Gaurav and the team do. Jeanne, do you have any experience with adult patients?
Sorry, I was on the chat. Can you repeat just short?
Do you have any experience with adult patients with
Not at all.
sclerosing cholangitis?
Well, not. I cannot comment on this.
Okay. Okay.
Sorry.
No, that's okay. That's okay. That's not a problem. The other question is, I think also goes to you. How was disease activity measured? Was it based on just imaging, or were they followed with circulating peripheral BRAF cells? We answered that. Was bone marrow tested for involvement of BRAF PCR?
No, most of them was tested on liver test, liver function with albumin, coagulation test, and imaging. The question of imaging is probably the key of the evaluation, and but it's not so simple because MRI are difficult to realize in young children who have a lot of movement. But it seems that there is no change on the DUCT3 related to the MAPK inhibitor treatment when it is done.
Okay. Thank you. Kathy, I hope we have time for another question. This also goes to Jen. The question is that patients with sclerosing cholangitis showing scattered CD1A and Langerhans positive cells in liver, how do we distinguish from reactive dendritic Langerhans cells in BRAF-B negative setting, and especially in the absence of known history of LCH? What do we recommend? Do we recommend staging and mention this in differential diagnosis about the possibility of LCH in such cases, or do we do something else?
Yeah, I mean, these cases are challenging. And again, apologies for the loud noise in the background. But in short, if it's a known LCH patient with disease elsewhere, if there is any type of biliary obstructive, sclerosing cholangitis, elevated bilirubin, GGT, I make a comment that it's associated with LCH in that setting. Now, if the patient does not have LCH biopsy proven elsewhere, then you cannot just go by 1 or 2 CD1A positive cells, because you can see more so, I think, Langerhans. Langerhans can be a part of a lot of different inflammatory conditions, and I've seen that with some Langerhans staining in other inflammatory autoimmune cases. So you have to really use the prior history, what's known, if there is any circulating BRAF in the blood or known in the bone marrow for all of those. But in a BRAF negative child that would have a liver disease pattern like this, I would still consider it hepatic involvement.
Okay. Thank you. And a question that I was asking myself from Mark, are there any preclinical or clinical data that would suggest that using MAP kinase inhibitor upfront as a way of cooling down the inflammatory environment in the liver prior to initiating cytotoxic chemotherapy drugs might be useful for liver-involved patients?
It's a very good question, but presently we have the retrospective data, and it's hard to move the indication. But I think that what we can say that the classic therapy, vinblastine and even 2-CDA or 2-CDA-RAC are not able to control such liver involvement, and so there is a room to evaluate such patient with the difficulty of the rarity. And so hard to say how to do that, but
yeah, well, perhaps we might have some more information from Dimitri's study, because Dimitri has used MAP kinase inhibitors upfront. I know his series is not large, but there is initiation of similar trials in Europe and in US, and then we can see, do we have a reduced incidence of sclerosing cholangitis in patients who had upfront MAP kinase inhibitor therapy. That might be a way of finding that out.
Well, still need to be evaluated. Can I ask a question to Jen about ontogeny of the liver duct? Is it like the other part of the liver? Is this something to associate with a resident macrophage or something like that? What is the embryology of these cells?
That's what we're investigating, right? This is the million-dollar question. I think once we figure out this and all of the different organ systems, I think we'll really be able to, direct our treatments and maybe preventing it. But I don't know.
Okay, thanks.
I think we have gone over our time. I think we've done about 8 minutes of overtime. So I'd like to thank you all. Thank you for people who have come to present, especially to Jen, who had to fight the travel and weather conditions. And thank you to Jean, and thank you for our presentation from Argentina. I think it's been excellent. I hope you have learned and perhaps get some inspiration to do more research in this area. So thank you very much, everybody. I'll see you at another webinar, I suppose.